degree in anthropology from Bowdoin College, and he was later named as a Fulbright Scholar in public health and worked in Costa Rica. In 2008, he completed medical school at Harvard and went on to do a residency in emergency medicine at Highland Hospital, where he remains today. He has been an emergency medicine physician for more than 10 years and is currently the director of emergency pain management and addiction treatment at Highland Hospital, Alameda Health System in Oakland, California. Dr. Herring also holds an appointment as an assistant clinical professor at the University of California, San Francisco, and he's board certified in addiction medicine. For the past several years, Andrew has been a leader in the field of implementing immediate treatment for opioid use disorder in the emergency room setting. He has led a series of pilot programs to launch medications for opioid use disorder in emergency departments throughout Northern California, with an ambitious goal of providing high quality addiction treatment in all California hospitals by 2025. He's the principal investigator on a 16-site California Bridge patient outcomes study. And in addition to these accomplishments, Andrew is a wonderful colleague. He's a site lead for a NIDA Clinical Trials Network study that is evaluating the effectiveness of sustained release buprenorphine in the emergency department. And I and Dr. Lawful have had the privilege of collaborating with him on this. He's an outstanding advocate for patients, a thoughtful collaborator, and a very inspiring speaker. I'm very grateful, Andrew, to have you here to share your experiences with us today.
Thank you so much. It is just a thrill to be here, to be part of the Healing Community Study in Kentucky, working with Dr. Walsh, Dr. Leffwell, Dr. Fernucci. It really is an honor. I can say very, very confidently that if it were not for Sharon's work, I would not be here. Just a real legend and mentor, and it's just an honor to be here. So I'm thrilled. So let's get started and start talking about how do we help people that are struggling with opioids in the ER, in our clinics, on the street, in jail, wherever we find them. Disclosures, right? I'm an ER doc. I didn't start out as an addiction physician, as a pain physician. I started out in the ER. And I've got a lot of guilt, of ambivalence and guilt and regret about how I practiced medicine for years. And just in the crush of being in an ER, there's a lot of use disorder patients, people struggling with opioids that just went right by me, deal with the abscess and move on. So it was quite a personal journey, learning from folks like Dr. Walsh and her work, and finding some actual tools to change how I think about people using drugs and what I'm doing clinically into something that's actually productive and helpful. So I work at Highland Hospital. This is where it's an inner city urban safety net hospital in Oakland, California. This is really what's taught me everything I know is the patients, providers, and just reality of working in this institution has been incredibly influential for me. I'm also now a medical director of our outpatient substance use disorder treatment program, where we do medically assisted treatment as well as behavioral treatment, case management, the whole 9 yards. So I do both, which is a unique place to be, and a really fortunate place to learn and see the different perspectives on care and how you integrate it and what the patient experiences on both sides of these typically divided experiences. Finally, it's just been this amazing ride to see this idea grow from a very small pilot, 1 hospital, 2 hospitals, 12, 52, and now expanding on to 200 hospitals, and seeing this whole cohort of incredible people, of pharmacists, social workers, nurses, physicians assistants, nurse practitioners, really grow a whole new aspect of their practice, not just clinically, but as leaders, as leading whole communities, seeing physicians go from treating individual patients to becoming medical directors of their public health departments, putting together regional systems for people struggling with drugs. So this is a moment, I think, for all of us where we need physicians to enter into this role of building culture, building systems, building a whole new way and a better way of treating people struggling with drugs. And so that's been the California Bridge, has really been the name for that work here in California. Um, so that's really where that's the basis of most of my experience, and it's been I think it's a really good place to learn, in that, from a functional standpoint, when things go wrong, I've generally heard about them. And with 52 sites simultaneously offering buprenorphine, I definitely saw a lot of things go wrong, and have done a lot of problem solving and learning in rural contexts, in urban contexts, in on the border with Mexico, racially diverse contexts, everything in between. So I've really seen a lot, and I hope that I can be as transparent and open as possible with everyone on this call to try to share lessons learned and perspectives from that. The basic model, it's not rocket science, right? It's pretty straightforward. It's use science, use evidence, find things that work, right, and implement them wherever you can, wherever that might be: clinics, emergency departments, inpatient, outpatient, jail, wherever. Connect what you're doing in any one situation, integrate it into a common sense system of care, so that people don't just talk to each other, they should be friends. The person who does discharge coordinating from the jail shouldn't be someone who, their number. You should be friends with them. That it should be a community of people that are working together, problem solving, being creative, being adaptive, to to tie together a network of care that works. And it all comes not from a goal to, fight opioids, or, extinguish opioid use disorder, but really caring about people, because their needs might take you in directions that you never thought you'd go. It's not simply about getting buprenorphine into people's mouths. That's a important component, but it's really about also, who are these people? Lots of people are exposed to opioids, illicit or otherwise, and don't develop use disorders. We're working with a group of people who have a use disorder, and they're complicated and have many needs. And our goal is to respect them and to learn from them and to do what we can, given whatever label we're wearing. Are we a doctor or a social worker? Whatever tools we have to help this group of people. And that's something that really, I think, helps guide into the future what we're going to do, which really we don't really know, right? We're kind of we're learning. What we know is that today there's a lot of what we do that doesn't work as well as we'd like. We're seeing overdoses, we're seeing people drop out of care. So it's a moment of creativity and innovation that's going to be driven by commitment to this group of people. So in our initial experience here in California, the surprising thing really was that physicians, nurses, PAs, they wanted to do this. We really didn't know. We thought maybe there were folks out there who wanted to do this. We had no idea that really it looks like the majority of emergency clinicians want to do this. They want to get into this role of identifying and helping people with use disorders. So we saw a really dramatic uptake across 52 hospitals. And within 14 months, we identified nearly 12,000 people. Nearly 8,000 actually got buprenorphine in their mouth, right? They actually got treated. Nearly 6,000 got a prescription, and nearly 5,000 showed up at their outpatient appointment. So something we're incredibly proud about, that really argues that this is a feasible and sustainable idea across a really broad and diverse set of community, rural, academic, urban hospitals. So, the other kind of amazing thing that happened with this happened during COVID. If you think about it, my God, just trying to implement large scale, health system change in the midst of a pandemic is just something that none of us saw coming. And to me, this graph shows where, when ERs became these terrifying places that no one wants to go, it looked right out of some science fiction horror movie with hazmat suits and all of that. but then the volume came back. So it just shows how robust this is. This is not a something that is a, you achieve it once. This is really fashioning a whole new and long-term role for emergency departments as a central component of a population level response to opioid use disorder in every single community in the United States. Like, that's where this is going to go. This is where this is the first step, is what you all are doing, what we're doing in California, but this is going to keep going for decades to come and really define part of what it means to be an emergency physician and what an emergency department is. Science, we're just incredibly lucky to have just this active role figuring out what are the best treatments. This is another sort of area that I've really felt very fortunate to learn from, with Sharon and Michelle Lofall and others there, also just helping us tease out in these very, very specific ways the experiences, the trajectories of people taking buprenorphine, precipitated withdrawal, worsening withdrawal, success, all that stuff has really, having a dedicated study to provide very, very detailed observations of these real world things that emergency physicians are experiencing is another real source that I've drawn on. So yeah, from all over the country, because the point here is that I'm speaking from California, and then you here in Kentucky have your own unique experience that is going to differ. But we do have this incredible network of people from Philadelphia, where the drug supply is clearly very different than it is in Seattle or that it is in Los Angeles. And so part of this talk, I hope, is to learning about your experience locally in Kentucky, because I know the only thing I know is it's going to be different. Okay, this is just I'm bringing this paper up is that I think it stands up pretty well. This is it's in the Annals of Emergency Medicine. It goes over a lot of the topics that I'm going to talk about today in a little more detail, written by some incredible colleagues of mine, Jean Marie Perrone and Louis Nelson. And we kind of go over some of the basic principles of treating withdrawal. And treating withdrawal and initiating buprenorphine are, for all intents and purposes, the same thing. This is another paper that I know is sort of a hot topic, is around initiation of buprenorphine after overdose, that I refer to people to, that I wrote with Mark Greenwald. And so we'll talk in more detail about this around the nitty gritty of pharmacology. And finally, this is just a slide that I'm committed in 2021. Basically, every talk I give, I really want to talk about this briefly. And that's that the physicians, clinicians need to enter the health policy space. And our voices around this idea of treatment or criminalization and the appropriateness of criminal policy versus treatment is something that needs to be looked at and scrutinized. And our voices are something that is important to get out there. So I hope you really think about that as a physician or clinician, how you might participate in this important dialogue. Okay, so now I think I just want to talk about the kind of gone sort of high level overview of things, and then just maybe go drill back down to just the level of someone who is experiencing emergency department care, and walk through maybe an ideal day at Highland. Now, I'm not so naive that I think that Highland is always like this, but this is sort of Highland on its best day, the way it's supposed to work. So when you walk in the emergency department, this is the volunteer desk that greets you. And right there, addiction starts here. Addiction treatment starts here. Ask about trying buprenorphine. The idea here is that when you're building systems, don't necessarily forget about the lived experience of someone walking in, just like you were at a store or any kind of retail outlet. Sometimes you'll have board meeting after board meeting, perseverating over the steps of a treatment protocol, 2 milligrams versus 1.5, this kind of thing, which is important. But then they'll just sort of forget the big picture of what it's like to actually access services. So emergency department technicians, volunteers, any kind of registration staff, you could be the most amazing, insightful, impassionate, empathetic physician in the world. But if the registration person is frankly hateful and discriminatory towards your patient, it won't matter, right? So paying attention to the culture of the whole hospital from the CEO down is really one of the single most effective interventions you can make to bring success to your narrow program. Like, I have a narrow goal. I want to get buprenorphine into people with use disorder. It might end up starting out with a whole system-wide campaign that talks about harm reduction and respect for people who use drugs and learning about evidence-based treatment. So this is how you walk in. And the thing that I love about it is it's fun. You know, when you've got tightness, you've got baggage around judgment, and you feel like you shouldn't be nice to someone because they're doing something wrong. You know, when you shed that off and you're like, oh my God, I can just be a human being and learn about their life in a non-judgmental, empathetic way. It feels good. People like it. And so you'll see a snowball effect of people coming towards the work, this idea of creating a movement. And you go through the whole system. So that's as you walk into the registration desk, and then you get triaged. And so this is our triage cubicle, where we have a nurse who's got a little pin that says, I can start you on buprenorphine today. And we've got another sign that re-emphasizes this culture that, you know, if you need help with pain pill, or you're struggling with pain pills or heroin, we can get you started on buprenorphine today. An important piece of this is not to be euphemistic. It doesn't say recovery starts here, or, you know, helping hands here to help, or some kind of hallmark thing. It really appeals to a very hard-boiled reality of life that many people are in, where it's about reciprocity and perception of self-benefit. Like, if it's not, people are not looking to go in and to submit to an abstract treatment plan set up by a physician that they don't know, don't trust. There's this sort of discipline and submission that many programs have either explicitly or implicitly asked of their patient. Like, you don't just get buprenorphine, you get buprenorphine if it's contingent upon this adherence to this, and these things. And a lot of folks are like, I don't need doctors. I don't like doctors. I don't like hospitals, but maybe this medicine could benefit me. You know, maybe today, maybe it's about feeling better for the next hour. And it's okay. You can roll with that, because that's your entry point to build engagement, to build trust, to collectively learn between, so that later down the line, you can help people, nudge them toward voluntarily deciding to take some of these steps that we all know are that are going to be good for them, such as abstinence, reduced use, and treatment adherence, and all of these other things. But you don't start with that. So paying attention to the triage thing, this has been one of the most remarkable experiences, you know, is seeing the folks that have come in because of this sign. So for example, I had one woman who came in with her 9-year-old who had sprained their ankle, typical ER case. They saw the sign, they went through their whole treatment course, took care of the ankle, and then she comes back, you know, a week and a half later, right, and reveals that she had been started on hydrocodone, acetaminophen, or Norco. Then she'd been cut off. A friend started giving her oxy, and then those got too expensive. And another friend said, hey, heroin is just the same thing. And boom, she's on heroin. She was ashamed and was looking for help. So there's no amount of surprise and kind of you can't make this stuff up. By creating an opening, accepting culture, people will come. And this is an important contrast to a push for universal screening. It's a complicated subject in that I don't want to say you should not screen, but I do just want to bring up that if you ask someone to divulge a stigmatizing disorder like opioid use disorder without demonstrating clear self-interest and benefit, people aren't going to do it, right? If you just want to raise your hand like, hey, discriminate against me, you know, hey, give me, you know, poor care, this kind of, they're just not going to do it. So lead with like, this is why you should tell us you have use disorder, because we're going to give you this benefit. And that's okay. So then moving in, so this is our fast track. Fast track is like an urgent care type of thing. You know, this is, the patients are not put into horizontal beds It's cubicles, it's chairs. There's no monitoring. There's no IVs. There's no mandatory testing. Nothing, right? And when you put the buprenorphine in the Pyxis, and the goal is to get, if someone is in symptomatic, if someone is not symptomatic, it's a little different. But if someone is symptomatic, I'm in withdrawal, everything happens after they're treated with buprenorphine. All the history, the details, they all come later, because if you try to do some intake, even if it's not very long, a 10-minute intake while you are in withdrawal, it's just a horrible experience, right? People are by definition anxious, irritable, intolerant of stress. They're distracted by their somatic experience. You need to fix all that first. So prioritizing all of your things, from sort of a Kaizen thing, the value added step is getting buprenorphine into their mouth and dissolving. So putting that up front and everything else secondary is a key structural thing you want to do. And then, when it comes to actually, what is the treatment? I really believe strongly that the best treatment is going to be the one that the patient, you motivate, nudge, educate for the patient to be able to make the choice. So this idea of choicebo, right, or placebo driven by the sense that you made the choice to do it. We try to integrate that at every step of the way. This is a little bit of a contrast where many protocols have kind of come out of a research background where you're forced into rather rigid a priori ideas of what treatment should be. In the reality, the patients you see in the ER, they might be starting for the first time, or they might be someone who's been on buprenorphine for years and they're traveling and now they fell off the wagon, they want to get restarted. How that the actual dosage and timing of how they're treated really might vary. So opening that door is important. Here, this is our menu, and it was sort of graphically copied off of a Subway menu for ordering a sandwich. And the idea is, you tell them, like, you move it across the table, and it's a laminated thing that says, hey, we're going to treat you as soon as possible. Don't worry about that. We're going to do what we can. This is a recommended starting dose. But if you have some other idea, we're open to that, and let's talk about it. And then after that, you promote, like, hey, you're going to feel better. Like, you bring positive emotion to it. And people, it matters. If people feels like, okay, this doctor knows what they're doing, they believe in the treatment, they believe the treatment's going to make me feel better, it does something magical, but it really does lead to actual objectively improved outcomes. So think about adaptive, human-centered protocols. So we're going to talk about strict protocols, but in the rubber meets the road, working with patients is, if the patient is dead set, like, I want 4 milligrams or I want 8 milligrams, be willing to adapt protocols to fit their needs, and it'll improve your outcomes. Then moving on, right? So think about what happens next. Who is your partner? So this is the bridge clinic. And so what this photo means for me is that if you have the most amazing low threshold, no barrier, walk right in, get treated with buprenorphine in the ER, but then they walk out, and the clinic, the first person they meet with is someone who's going to tell them that their insurance is no longer active and they have to come back next week, your program's going to founder on the rocks. So having a strong clinic partner who shares the same values, the same philosophy of care, and is committed to the same set of structural adjustments that enable low threshold, unimpeded, no barrier care is essential to a successful ED program. It doesn't mean it's futile to do it if you don't have that, right? If just getting a prescription or just treatment, that's worthwhile. But to really flourish, it's this combination of a passionate, outpatient physician and a committed set of emergency physicians that work together, really breaking down the barriers to make this flow of patients. The other piece to think about is around choice is, what if they don't want the buprenorphine, right? There's a lot of people who are struggling with opioid use disorder who maybe the time you meet them, they might not want the buprenorphine. They may have had a bad experience or they might have something else going on. Who knows what? The You shouldn't care about them simply as a target for buprenorphine. You care about them as a person. So it means you follow them wherever they go. For me, this means that we all have to be harm reductionists. This split between physicians or evidence-based care and things like Alcoholics Anonymous or sort of informal peer-based care. And then harm reduction is this very particular American reality that if you step back, doesn't make a lot of sense. First, do no harm is the primary vow of a physician. So if someone's not ready for buprenorphine, maybe they want methadone. So you should know how to start methadone in your ER. And maybe they need referral to pain management, or maybe they need a clean needle and advice on how to safely find a vein. As an emergency physician, I certainly never want to treat a spinal epidural abscess again, right? I mean, some of the most horrible M&Ms that we see are these missed spinal infections, endocarditis, all these things. These are preventable diseases. Maybe they need to be screened for hepatitis C. Maybe they're a candidate for PrEP and Truvada. These are all things that need to be wrapped in to care. And I hope that we embrace them. One of my mentors is Loris Maddox. She was the executive director of our local harm reduction agency and is now a state lead for harm reduction in California. She just calls this no shit science, right? It's pragmatic compassion where you're looking for ways that you can move people away from harm towards some sort of benefit and health in their life. And you're using every tool available to you: medications, harm reduction, naloxone kits, needles, homeless shelter vouchers, interpersonal violence, the intersection of suicidality and overdose, addressing mental health. All these things are really what is going to define a high quality buprenorphine program in an emergency department. This slide to me is just to remember how important it is to partner around the logistics of medications. It's this tightrope, this high wire act, where particularly in the initial phases of treatment, a single missed dose can really drive people one direction or the other, deeper into engagement treatment or away. So you might be able to put together your prescription. You do everything right. You have the most amazing program in the world, and you've got the most amazing follow-up clinic waiting for them. But if they go to the pharmacy and the pharmacist is rigid, rude, they don't have assistance to establish their insurance or emergency insurance or some way to cover that gap, you're going to lose people. So broad partnerships that include pharmacy, insurance, benefits, your local payer, the public health department, whoever you can cobble together to try to create this unimpeded or uninterrupted flow of treatment is another essential task to building a functional program. Because we know that if you have, when you work with people, you see that this is our system. It's a truism, is tragically fragmented. It just boggles everyone's mind if you really step back, as how many walls there are between us. And that's experienced fundamentally as hostility. Patients don't think like, oh, I understand, that like your funding is based on certain, patient populations and eligibility requirements. And it doesn't make any sense to them at all. It feels like the system is out to get them. It feels like the system doesn't care and almost is intentionally pushing them into harm. So it's experienced as hostility. So your work is really trying to fix that. And this is the way to do it. It's with a substance use navigator. So this is Zaire and Kelvin. These are two of my friends here that work with me in Oakland. They are recruited out of a local mentorship program for local youth that are interested in in careers in medicine and science. They are relatable, they're from the community, and their job is not to go to bedside and fix the patient. Their job is to go to bedside and fix the system so that it works for the patient. So these guys, they know, all of the pharmacists in our local area on a basis. They know how to do emergency Medicaid applications. They know how to relate to people, and they're given power in our program. And what do I mean by that? I mean that they actually are there. They help us make decisions. It's not me in a back room deciding what the care should be in the bridge program at Highland. They're the ones that are all sitting around the table with us to actually design what we're going to do. What is the overall goal, and what are the nitty gritties? Because they're local knowledge, their understanding of our patients' needs, both those spoken needs and their unspoken needs, is essential to strategically guiding what we're going to do. So it's the message is to bring substance use navigators into your program, but not just bring them in, but bring them in as leadership members so that they're able to have power, and that's going to shape a program that works. Right, if you're really fortunate, you can use this as a springboard to have a community of people who actually have struggled with use disorder in the past or currently, and can also be a voice, the idea of a patient voice, in shaping care. Finally, there are there are realities around race and class that in affect the care for in every community in the United States. So your identity, my identity as a suburban white male, there are just things I am never going to see. I can read as many books as I want and as many essays as I want, and I'm going to have blinders that I just won't understand what's going on. So having folks like Zaire, like Kelvin, who can also provide guidance on how to do this in a way that's culturally and racially appropriate and really meets people's needs, is another really essential way to advance equity in your program. Okay, so this slide here, this photograph for me just means this: where does Suboxone, where does buprenorphine exist in someone's lived life? They've gotten through the early part, right? They've initiated in care, they've got it all figured out, and now how do they build things back? And for me, touches on this idea of trajectories of treatment on buprenorphine. So this was from a slide or a study in Canada where they followed people starting on buprenorphine for several years, and they came up with this idea of trajectories, and it really resonates with me. And what you're going to see is that many people, there's a subgroup of people, the low-hanging fruit, where they are just, for whatever reason, they are just ready for help. So all you do is you open the door, you put buprenorphine in their mouth, and they're off, they're done. It's amazing. They stick with care, they engage in care, they go back to school, go back to job, go back to being a parent. All these wonderful things occur. There's another group of people who, there's a honeymoon period. They're enthusiastic, they're motivated, they engage. It's not, the first couple of weeks actually are the easiest for them because they're really there. And then even after repeat engagement with the whole team, they just start falling off. They just drift off. Something is not working for them and they discontinue care. There's another group who initially they just struggle, right? They don't make their initial appointments. They make one appointment and they lose their medications. They lose them again. They lose them again. They lose them again, right? They just struggle. They're not doing well. And then out of the blue, kind of when you least expect it, something snaps, and they really find that latch point. They engage and they hang in there with treatment. That was sort of the green line. And then there's this other group of folks where you do everything in your power. You put together the most amazing suite of multidisciplinary services, going after the social determinants of health and all these different things, and just nothing sticks. They're just not gonna stick with buprenorphine treatment, and that's really your harm reduction population that you're constantly reinforcing harm reduction with naloxone distribution and clean needles and addressing homelessness and all of these kind of things. So when you're starting your program, I think many people and myself, we kind of had this linear idea that it's like, all right, I'm just like fishing and I'm going to find the fish and I put it in the conveyor belt and it goes off. And it's this line from initiation through treatment. And the reality is much more complicated. And so in function, what this means is that most of the people at any one cross-sectional moment in time of the people that you've interacted with your emergency department program will actually not be engaged in care. So if you go back to think about what's your goal, is your goal treating people with buprenorphine? No, your goal is helping people with opioid use disorder. So at any one point in time, most of your target population is actually not taking buprenorphine. They're not engaged in treatment. So what you're doing in the ER is you're holding this community of people and just constantly trying to shift these curves to find any little moment, any little opportunity to bring someone out of this pool of folks who have been exposed to the idea of treatment. Maybe they've taken 1 or 2 doses, and then motivate them, create the pathways for them to flow into maintained treatment. Okay. The so this slide is just I think, you all, we all are really immersed in the realities of fentanyl and the death that comes with it. It is certainly moved west. It was something that we didn't have to deal with that much until recently, but the last year or two has just been really dreadful. And we're just seeing these huge spiking rates out here. So now I kind of wanted to get into the nitty gritty of treatment and go into some real sort of specifics on dosing and things like that. Okay, cows. So sacred cows. The thing to remember with cows, it's incredibly useful heuristic. If you want to learn like what are the physiologic, what are the objective and subjective experiences of opioid withdrawal, the cows is excellent. It was not designed to be a screening tool for appropriateness of buprenorphine treatment in the clinical area. So it's much more of the reality is much more that the inter-rater reliability between nurses and doctors is all over the place. The problem is if you hardwire it into a protocol, what a oppositional physician, nurse, administrator can do is they say, whoa, you can't use buprenorphine until every single staff member is trained and passed competencies for the clinical opioid withdrawal score, which is just a way of really just kind of blocking. So what I would encourage you all to use cows. It's an amazing, amazing scale. I use it every single day, but you don't require it. Right? Because if someone is like, I use 3 grams of heroin a day, I haven't used in 2 days, and they're yawning, drenched in sweat, rocking back and forth in front of you with pupils that are like this, you don't need to do a cow score. You need to give them buprenorphine. So just to remember these little functional things. All right. What we really end up doing is basically you eyeball them, you see them objectively, and then you just ask them, how sick do you feel from withdrawals? And if many people have been exposed to buprenorphine. So it's these 2 questions of how sick do you feel from withdrawals? And then do you feel ready to take buprenorphine right now? And you will find those 2 questions are, if they say, I feel very sick and I feel ready to take it right now, 99% of the time, you have a credible historian that's given you accurate information that you can act on clinically. So that can kind of cut through. And this is just a fun paper that Andrew Tompkins did, who was a colleague of mine here at UC San Francisco, where they actually intentionally made people sick from naloxone. And they did the cows, and they just did this one unidimensional, how sick do you feel? And you can see that the curves are really similar, so you can get very similar responses from this basically one question. And then if you're unsure, the timing's off, there's something, maybe they're also intoxicated, they're coming off of stimulants, or Also, something else is going on. You can use the cows as like a double check. All right. So testing. The the here the You don't need to do urine testing before you give someone buprenorphine. This is not going to go well, right? It's urine testing is like the bane of emergency medicine. It seems so simple, but it's never simple. It's always delays and all this kind of stuff. So you certainly can choose to do urine drug screen testing, and there are wonderful physicians who are able to use urine drug testing in a very functional, patient-centered way to advance treatment outcomes. No question. In the ER, it's really not necessary to initiate treatment, and it should never stand between doing the value-added step of treatment. Um, and this includes pregnancy testing. People can choose, you should offer, but they don't have to take the test before they're treated. Now, dosing during withdrawal. This is again, an evolving area, but you'll see that that many folks, many protocols, come out of an experience of transferring people from methadone to buprenorphine, which is different. If you have someone who's using morphine or heroin, the most of the time, this is a really pretty easy transition that it can go quickly. So the traditional model that has 2 to 4 milligrams every 2 hours, maximum of 12 in one day, and then the next day maybe 16, is sort of these 3-day induction protocols. It doesn't work for most emergency departments. So most of us are going to go much more quickly. And I really, the people who taught me this were my physician's assistants, where we initially started with these traditional protocols, and then just like everybody needed 8. So why are we doing 4 and then 4? So we just kind of gradually ramped up. So being really and this is going to vary by your patient population. We're having fentanyl come in, and there's some questions about lower starts and all these sort of interesting things. But if you're follow your patient's lead, and have a freedom that understand that this dosing can be flexible, and that buprenorphine is quite safe, right? It's a there's a ceiling effect on it. So we have not seen excess sedation. We have not seen respiratory depression, really, basically in any of the patients in the California Bridge. Thousands of people getting treated with larger doses of buprenorphine, 16, 18, 24, 32. That's just not been the issue. The issue is patient selection around medical illness. So what you'll see is that we've had people present to the emergency department who are complaining of opioid withdrawal, but they turn out to be in DKA, or they turn out to have thyrotoxicosis, or they turn out to have appendicitis, or they turn out to have pyelonephritis, or they turn out to have other kind of bacteremia. It's really common. So in critically ill patients, renal failure, all this, those are the patients that you really do need to be careful with. So the actual respiratory depression, the somnolence of buprenorphine can be impactful in someone who's also critically ill. So it's this two-pronged message of healthy ambulatory patient. You're just not going to see clinically significant sedation, respiratory depression. In an ill patient who's being admitted with some sort of organ failure, you should go slow and low with that person. Just a functional thing is, don't forget, people have to let the buprenorphine dissolve in their mouth. It seems like a small thing, but you mark my words, when you start a buprenorphine program in a new hospital, the first thing that happens is that the patients are all swallowing the pills because they forget this step. So really letting it dissolve. And the more distress you're dealing with, so post overdose or really severe withdrawal, the more people just want to get the treatment in, and they drive and they actually swallow it. So it is sort of this ironic event of the folks who are most desperate for relief are the ones most likely to swallow it, as opposed to letting it dissolve. So this is just the basic CA bridge model, right? You can go low, you can go big, but this is just the basic model. If you're one sort of take home, number one, anticipatory guidance that this is going to go well, but there might be some bumps in the road. It's that dual message, like, you're going to do great, but there might be along the way, you might feel crummy. You should know that that will pass. So that is really important to tell people that. Stop using and wait until you feel sick from withdrawal. For most people, this is in the 6 to 12 hour range. And then when you feel ready and you feel sick, take 8 milligrams. Let it dissolve completely under your tongue. And then you can take repeat dose as needed, every half hour to 2 hours to feel well. And after that, no matter what you took on the first day, start on 16 milligrams a day. That's the core, out of the box, unmodified CA bridge model at our hospitals out here. So now maybe just real quickly a time check. How are we doing for time? Because now we're going to get into some weeds. We're doing about 10, is that about 10 minutes? Okay. So this is where we're kind of going off into what we don't know. So for folks that are interested in dosing, but what we're seeing is that beyond that basic model, because there are people who will go into precipitated withdrawal, right? So there's enough that'll make them feel terrible. And then there are other people who the dose it won't make them go into precipitated withdrawal, but it won't treat their emerging withdrawal. So it's underdosing. We're generally seeing a coalescence of experience that just a tad of buprenorphine. So, a 1 milligrams or a Butrans patch or swallowing a 2 milligram tablet or something like that is generally innocuous. So you can be high, high as you want you've just injected fentanyl, you've just used heroin, and you can take a little bit of buprenorphine and you'll be fine. And then there's this dose in the middle, 2, 4, 8 milligrams, this dose where it's enough buprenorphine to strip whatever opioid is left in your system, but not enough to replace. So that's where we see the most incidence of precipitated withdrawal, right in this middle zone. And then there's a big dose. So this is an idea of 16 or 24 milligrams all at once, which clearly causes a lot of displacement, but it also is enough to kind of come back and provide enough signal that the patients feel well. So this idea of microdosing and macrodosing is a kind of exploratory zone where a lot of us are seeing similar events where it depicted here, this would be a Butrans patch or a Belbuca or some little bit of buprenorphine that doesn't really bother people. This middle zone, it's enough to blockade but not replace, and then the big dose. That's the idea of the single big dose. And the way I think of this is just when you're kind of trying to figure out like what's happened with this case, the things that are happening there is you've got the agonist effect of the buprenorphine. It's acting on the mu-opioid receptors and all those downstream effects. Then you've got the actual displacement moment. There's something special about that moment where the heroin or fentanyl or methadone is ripped off the receptor. And that's a thing, that's an event in this equation. And then you've got the blockade. Just once it's set, it's not going to let other substances act on the receptor. So with this formula, you can usually piece together at least some reasonably logical narrative of what happened to any individual case, good or bad. Okay, and so that's just the idea of this balance. And so as we're trying to figure out the ideal induction strategy, is it going to be microdose, macrodose, something in between? Is it going to be an injectable? These are the things that we're balancing, and it's an exciting moment where we're trying to figure out what works right now for contemporary folks using in the community. I think that as we figure this all out, it's good for us all to remember the pharmacokinetics, and the caveat here is there's the actual plasma concentration of buprenorphine in your blood, and then there's what people actually experience, and that's not one-to-one at all, and that's a little bit sort of implied by these curves. And that's definitely important to remember that it's not that simple. Just the concentration of buprenorphine in your plasma does not equal your actual experience, but it's clearly correlated. So sublingual, it goes in really fast, right? It absorbs and it goes in really fast, it spikes, and then it goes down. So you're going to see people who are fixed, right, for an hour or two, and then they feel crummy again. So that really fits, the actual pharmacology of the drug. The And so the other piece of that is that this is when if things are going to go wrong, this is when it's going to happen. It's going to happen in the first 2 hours when they're in the ER. So if you're going to have respiratory depression or any of these adverse events, they're going to happen when they're under your care. They're not going to go home and have a delayed adverse event. Just to really prove not prove, I should say, really suggest, you should all just know, this is this amazing physician, Dr. Ahmadi, in Tehran, where they have absolutely enormous programs, these enormous hospitals. They have a many centuries old opioid use disorder problem. And this is a case report where his protocol involved giving a single dose of 120 milligrams of buprenorphine to people as a detoxification dose. I am not advocating to do this. Please do not do this. I just am saying that it's out there. This sort of fear of the higher dose of buprenorphine is probably a little probably unfounded. The respiratory depression has a potent and well demonstrated ceiling. Just to re-emphasize this point that we've seen for decades and has been proved over and over again. And you're really going to see this play out in your ambulatory patients. Just being careful for your sick ones. And of course, some of this work was done by our own Dr. Sharon Walsh. This is these incredible results, right, where you see that the dose of 32 milligrams of buprenorphine, versus 8 milligrams is remarkably similar in terms of people's actual experience. So wrapping up, patient-centered care, we talked about this idea, talking people through it, providing the options, making it friendly, making it encouraging, make some wiggle room. I've presented sort of this idea that you can go really big and go really, really large and go anywhere in between. Like, how do you choose? Like, who gets the big dose? Who gets the micro dose? I don't think we've got a great objective idea of who that's going to be. The main person guiding you to do that is at some level going to be the patient. So we talked about the big dose, the little dose. I don't know if this is possible for you in Kentucky, but we have a lot of really wonderful good luck with the idea of a transdermal buprenorphine. There's some magic that happens if you can just get a little buprenorphine into someone's system, when they're still using, and then they enter abstinence. So let's say they're using fentanyl. You put 1 or 2 patches on them, so they got 20 or 40 micrograms per hour of buprenorphine going in. They abstain for 12, 24, as long as they can take it, and then they just start regularly. That just works very well. So there's other ways that you can create that by cutting up the strips really small or swallowing tablets, all these sort of kind of, sort of ingenious, ER type things to just basically this fundamental thing of getting a little bit of buprenorphine involved so that you can tolerate abstinence and then start normally. This is known as the sort of variation of what the idea of microdosing. I'm not a big fan of microdosing as a term, but just the idea is just slipping in little amounts of buprenorphine. I don't do cross tapers in the sense of there are some folks in the ambulatory who will give you this tiny dose of buprenorphine, and then you're actually told it's okay to keep using your illicit opioid, which makes a lot of sense almost as a harm reduction standpoint. But at some level, from my pain medicine hat, where if someone has a diagnosis of pain, you can co-prescribe buprenorphine opioid use disorder and a full agonist opioid for pain and execute an actual cross taper where you move from fentanyl or methadone onto immediate release morphine, and you do the switch. It works wonderfully. If you're working the addiction sphere, you really, it's very difficult or you have to do some really elaborate documentation to prescribe someone morphine while you're also initiating them on buprenorphine for an opiate use disorder. So most people don't do that. And so what that does is it really shifts risk onto the patient, saying like, okay, I'm going to give you the buprenorphine, but you're going to have to still go and purchase fentanyl from your dealer. So I'm not a fan of outpatient ambulatory cross taper or microdose protocols. Inpatient is a whole different story. Pain medicine, different story. Injectables. The one of the things to think about is just, you know, this idea of extending the power of an interaction. So if you're in the ER and you manage to get 4 milligrams into someone's mouth, they're going to feel partial treatment of their withdrawal for a relatively short time, and then they're going to go back into withdrawal. And if you don't have an airtight system with your pharmacy, with others to get that prescription, you're going to have a high rate of failure. The more buprenorphine you can get into someone before they leave your ER, the better they're going to do generally. So if they can get 16, your window gets longer. If they get 32, their window gets even longer as they confront this fragmented hostile system we talked about. Enter injectables. So our study led by Gail D'Onofrio, which is really a fantastic idea. What if we used an injectable right from the get-go as part of their induction? Early signs are this is a great idea. You know, we're seeing that we've had patients who've struggled with this coming into the ER, getting started, falling off, getting started, falling off, and they finally stick where we get a, you know, the Braeburn CAM 2038 product into them in the ER, and they follow up in Bridge Clinic and they get a Sublocade 30-day injection, and they do great. So I'm very enthusiastic about injectable formulations of buprenorphine. I think it should be thought of as easier, not more complicated than sublingual. It shouldn't be like, oh, I'm going to do injectables when I become a super expert in buprenorphine. I really see it the other way around. If I was a primary care physician, I would probably start with Sublocade or something like that, because it takes away all of that effort around obtaining, storing, dealing with lost prescriptions, all of that stuff. So the basic idea with these injectables is they're marketed as 7-day or 30-day. All of that's a little bit to do with marketing. It's just a ball. It's just a 3D ball of buprenorphine that's injected underneath the skin. And the size of that ball is how long it's going to last. And then in the first, you know, 1-2 days, you get this big spike. You know, you get so people will feel that. So if you're doing 300 milligrams of Sublocade, they're in withdrawal, you inject them, they feel it in 15 minutes. Whereas if they're doing a 24 milligram CAM, it comes on more slowly. Just has to do with the size of this ball, and then it's going to trail off over the next days. So for some folks, they're going to feel completely treated for 6 weeks. Other folks feel great in the first week and then not so much after and in the subsequent weeks, as it's sort of as those levels start to decay. So again, follow your patient. They're not lying to you. They might need augmentation or more frequent injections, things like that. Okay, so quick cases. Buprenorphine after overdose. This is something that, you know, hasn't really ever been formally studied, but as far as I'm able to ascertain through giving these kinds of talks and really eliciting feedback from folks all over the country, is the people that are doing this, something about exposure to naloxone makes people receptive to buprenorphine. That they tolerate and do well. I've seen it work with any number of dosing levels, 4 milligrams, 8 milligrams, 16 milligrams, all these different things. You never want to intentionally induce withdrawal for the purpose of initiating buprenorphine. That's not what you want to do. But if for some other clinical reason they're found unconscious, they have a low respiratory rate, you're unsure what's going on with them, you need to define the toxidrome. Is this a head bleed and sepsis, or is this, you know, excess fentanyl? Naloxone is going to tell you that. You administer the naloxone, they go into withdrawal. You should not feel that you need to hesitate. That is a perfect moment to administer buprenorphine. Buprenorphine will outcompete the naloxone. It will outcompete the fentanyl. It will sit on the receptors. People feel better, and they're protected from subsequently going back down into respiratory depression from whatever it is they overdosed on. The rub is that, you know, these overdoses are complicated. You know, you're often sorting out, is this alcohol, benzo, GHB, you know, trauma. It's a real complicated thing. So of all the people who get naloxone in a given system, the people who end up really meeting criteria for it, you know, you're thinking like 20% at most, probably, that will be appropriate for that. that in the other piece of it is that this is something that you can obtain verbal consent for. So you're not going to be putting in buprenorphine to someone who's agitated, confused, delirious. That's not the right person. This is the person who you've gently and appropriately reversed with naloxone, who's awake, alert, and feeling crummy. And you can tell them like, hey, we can give you buprenorphine right now, and it'll help you, and it's something you can continue, and it'll help you not use drugs in the future. And have that conversation. And if they say yes, you can proceed and give them buprenorphine. It's something that I would encourage people to do in their practice. So this is a series of cases, an amazing set of cases. These two guys, they're one of them is still in my practice now, 3 or 4 years down the line. But they both were heavy heroin users for multiple years who were coming to Highland with the intent to initiate buprenorphine. In the parking lot, they bought a pill that they thought was lorazepam to kind of take the edge off. It was actually pressed fentanyl, and it was must have been carfentanil or something, because they both overdosed in triage. So they both went down and had to be brought back. We administered naloxone and gave buprenorphine right afterwards, and they did great. And this is the typical course of what I've seen. There are programs going on in Camden, New Jersey, as well as Contra Costa County here in California, where we're actually giving paramedics buprenorphine, and they're administering buprenorphine to folks in the field who have been reversed with naloxone. This case is just to talk about the abscess. So in the ER, you're going to deal with pain. So you can treat opioid use disorder, you can induce people on buprenorphine in the midst of painful conditions. And it just requires understanding multimodal analgesia, which ERs are getting really, really good at. So this is really your regional anesthesia and ketamine and gabapentinoids and IV lidocaine, all on top, all used in conjunction with buprenorphine. It's a long topic in itself, but I just wanted to put this slide up that buprenorphine in acute perisurgical or procedural pain, it's not a contraindication. You can do both, and this is just a great conversation to have with your anesthesia department, your pain division, to figure out how you're going to manage people who are on buprenorphine who come in with acute traumatic injuries, and how you're going to initiate people who are coming in with acute traumatic injuries or other procedural needs. Okay, so I think we're kind of about come up to our hour. And that was the conclusion of my prepared slides. And I'd really love to dig into some of the details that I sort of whizzed by here with the assembled group.
All right. Thank you, Andrew, so much. That was really wonderful. We have had questions come in advance of the presentation, and I think that probably there's plenty of people that have questions that may also want to speak up or put them into the chat. And I'm going to introduce the moderator for the question and answer period, and that is my dear colleague, Dr. Laura Fanucchi, who is an internal medicine doc working in infectious disease. She works at UK providing care for patients with HIV. She also leads our inpatient addiction consult service that's called ACEs. And she's been instrumental in making a lot of change in our own healthcare system. And she is also a critical player on the Healing Community Study. And so Laura, take it away.
Thanks, Sharon, and thanks so much, Andrew, for talking with us today. I think folks listening, please feel free to type questions in the chat, or if you'd like to come off mute, you're welcome to ask. I can start the conversation if it sounds good with some of the questions that came in during registration. Does that work for you? Okay, so a kind of common theme to summarize is what have been some of the most significant barriers to uptake of a program to initiate buprenorphine in the emergency department? And I guess part of that is, how do you convince skeptical physicians that beginning treatment with buprenorphine is the best treatment?
I think that really what we've seen is having a place for them to go is that was like the number one thing. You know, ER docs are just terrified of, you know, rightfully so, of bounce back treatments or sticky in, you know, engagements that they can't extricate themselves for, and you sign out and you becomes a burden for your colleague who then says, "Oh my God, I can't believe Herring, you know, gave this guy buprenorphine, but now he can't fill it and has nowhere to go. What do I do?" And Andrew's gone. So having that clear goal, you know, having a, you know, being able to walk into your department and say, "Look, there's a clinic. We'll take walk-ins at Thursday from Thursday afternoon. So just get them to Thursday and we will take care of everything else." Taking that worry that they're not going to have follow-up off the table is probably the number one thing. Because in terms of adoption of new practices from other fields for whom emergency physicians might not be, you know, that familiar with, that's actually what we do. Like that's like how we define our field, is really adopting and modifying the expertise of other fields and applying it to these you know, myriad you know, unbelievable circumstances that we see. So constitutionally, emergency physicians are quite willing to wade into waters that they're not familiar with, but they need to know that they're going to be someone on the other end of the line that'll take the care. So that would say is the single biggest thing.
Thank you. So another kind of question that you touched on some, but to just get into a little bit more detail with fentanyl, and we are seeing a
Yeah.
lot more of that here.
Yeah.
I think we were a little later than some other parts of the country, but it is fully here. Has it, in practicality, has it changed your induction with patients in the emergency department? Does it change kind of how much withdrawal you all are looking for? Have you seen difficult inductions? I think there's a lot of hearsay around fentanyl in terms of difficult inductions, but it's hard to know how much is really changing how we maybe do things in the clinical setting.
Right. Yeah, this is I mean, I'm not going to have an answer for this question of fentanyl, but I certainly have observations. And that's it, that most the natural history is that most of the people I work with, they had some trajectory that involved, you know, that ended them on heroin, and then they became heavy users of heroin and graduated, so to speak, to using fentanyl. So fentanyl is not just a substance, it's a marker for severity of disease and how profound their dependence is. And whether or not you're a pain physician who is working with a soldier who is coming back from, you know, Iraq and is on, you know, hundreds and hundreds of milligrams of hydromorphone a day for their pain, transitioning that patient to buprenorphine is going to be tricky. The same thing is true for folks who have really just profoundly big disorders that you often see with fentanyl. So that's one thing that has nothing to do with the sort of specific pharmacology of fentanyl. So another thing is that most of the inductions we do just by cultural practice are high dose. So we just don't do slow, low inductions in general. So most people are getting 16, 24, 32 milligrams very quickly. So that's just sort of been a long-standing practice. And in that setting, most of our inductions go very well. And many of those folks will end up being morphine negative on their urine drug screen. So the overall experience we're having is that this rapid induction goes well with fentanyl. It often might you might have a situation where their initial dose, they feel a little bit better, but a little crummy. And you just got to be willing to chase it with more buprenorphine till they're feeling well. And in some cases, that dose might be quite high, 32 or more. On the other hand, we are definitely hearing these anecdotal stories of complete train wreck, cases where someone is 18 hours out, they look great. I mean, I should say they look appropriate for buprenorphine. They have big pupils and they're sweaty and they're yawning. They get buprenorphine and they feel awful. And you give them, and you do the high dose. You give them 8, and then you give them 8, and you give them 8, and they still feel crummy. So when you dig in on those cases, so far, a lot of them have other things going on. They really do. So benzodiazepine withdrawal that's occurring simultaneously, alcohol withdrawal that's occurring simultaneously, methamphetamine washout that's occurring simultaneously, medical illness. There's often complexities there. Finally, many patients are getting gun shy, so that there's definitely also word getting out in the using community around fentanyl and buprenorphine. So you'll get folks that are afraid to take buprenorphine. So for them, we're really relying on this, micro macro idea where we get a little bit of buprenorphine into them. We preferentially use the Butrans patches, and then they abstain. And those folks in a small subset have done really well. We also find that Sublocade in the injectables is just a dream for fentanyl patients, because let's say no matter what you do, there's going to be some discomfort that occurs during induction. If you have the choice to discontinue treatment because you're feeling crummy, you might. Whereas with the injectable, there's a certain degree that you're along for the ride. And all of these patients, even the ones who might have really not feel very well in the first day, they settle out, by day 2, day 3, they feel better, they take more buprenorphine, and they stick with it. So if you can just get them through there, they'll continue with treatment. So those are some of my observations and thoughts at this time about fentanyl.
Thank you. That's really helpful. And we have also had some good success with Sublocade in
Great.
our outpatient bridge clinic. Yes, absolutely. I think it's a great option for people, and we're hopeful to see the new product coming out sometime soon. So there's a question from Dr. Roger Humphreys, the chair of our emergency medicine department. I think you met him.
Yeah.
You were here in Kentucky.
Yeah.
So his question in the chat, or Roger, if you want to speak up, would you like to?
Oh, sure. Yeah. Can you hear me okay?
Yep.
Yeah.
Yeah. So just this, some of our colleagues they're just kind of old school at times, and they think that the opioid epidemic is just cycles like it'll cycle like every other drug problem we've
Right.
had in 20 years. And so what would you say to them if they say, I don't want to use buprenorphine because that's just one drug substituting for another drug? What would your response be?
I that's a lot of people have that. You see that attitude not infrequently. I think for me is that it just getting you, if this was your son or daughter, you'd want them to survive that cycle, right? Because at some level they're right, that there are most use disorder epidemics do have a natural history, whether it's gin or whatever. Things do go up and go down, but if you're dead, that really doesn't make it matter very much. So in this sort of moment, even if it's, let's just say you accept that paradigm, it's an opioid, it's substitution. At some level he's right, it is just another drug, but that's the drug that's going to keep them alive, right? And then wherever they're at in that point in their life where they're having this very high risk use, you translate that into a very low risk use, a basically no risk use if they stay on the medication. And then over time, you can work with all these wonderful people, counselors and case managers and employment and education therapists that can help them move into another phase of their life where they're able to choose and successfully avoid the drug. And then at that point, if they're able to, they can transition off buprenorphine, or they can stay on it as a maintenance therapy forever and be a great dad and be a great employee and be a great student, all these things that are just not going to occur if they're buying fentanyl and, in some parking lot. And, that's just, it's a real pragmatic, thing that you can offer someone. I don't know if that resonated, but that's one idea for how to talk with that person.
No, I think that's a great perspective, and I think that that's great comments.
Are there other questions from the group?
Hi, Andrew. This is Michelle Lawful. Thank you so much for your talk today. It's just wonderful. It's wonderful to see you and your optimism, and it's just incredible how you've been able to expand care in California so quickly. I was really curious about Cal Bridge's connection with EMS, and just wondering about if you could speak more to how that ended up really happening and who spearheaded that, with thinking about EMS almost like thinking about overdoses like a stroke or MI, and having those kind of centers. And then maybe if you could extend, like if you saw at all as that grew, any real change in the perception of these patients, like how it affected stigma. I think stigma is the biggest impediment for us here in Kentucky and a lot of the southern states. Like it's really a burden to doing anything. So
thank you for those comments. And EMS. So basically, this was Rachel Harroz in Camden, New Jersey. She's an amazing emergency physician and addiction physician, works outpatient, inpatient. There's a lot of local public health work. And she just started doing this. And I can't remember how I heard about it, but I was like, oh my God, that's crazy. What's going on? And I talked to her, and she just explained that they were confronted with, these huge numbers of folks who would overdose and then refuse transport. And they needed to try to do something to make them feel better and stick them in the care. And they initiated buprenorphine on the ambulances. And it seemed like an amazing idea. So we just started thinking about it out here in California. Not just in New Jersey, they're restricted to just after overdose. And what we kind of stepped back here and said, okay, well, at some level, if the first wave of the bridge was repurposing the emergency department as this 24/7 resource to now do opioid use disorder care, then the emergency medical service, or EMS, is this enormous additional setting, with people, staff, and interactions and places and resources that had no attention given to it as a potential touch point for someone using drugs, as a potential place to identify an initiation treatment, whatever that might look like. The focus might be on buprenorphine and getting it onto the ambulance and all those structures around it. But really the big picture is, just like you said, is you might have a paramedic group who very often might have, they kind of culturally kind of lean into fire, law enforcement. It can be a little tough. And you kind of bring this, empathy, compassion, evidence-based treatment into that culture. We were worried about how that would go over. In Contra Costa County, where now we've trained hundreds of paramedics, it was remarkable. Paramedics, they want to fix things. They want tools. They don't like being in this sort of futile, difficult spot of return overdoses. So they were incredibly receptive. And I'm most sort of interested now in just that what they can do. And I don't really know the limits of it, but it's not just buprenorphine. Buprenorphine is a anchor to get them thinking about helping and treating people. But there's a whole world of work to be done to integrate those amazing people that are out there 24/7, 3 o'clock in the morning at the apartment complex parking lot. They're there. How could you equip and train and support them to do the best possible thing to support a long-term outcome in someone who's there? And all the bystanders, all the family and friends that are there, they're at ground zero, literally. And so that's where that idea of a opioid receiving center came, because clearly if you've got a paramedic who's like, oh, I gave him buprenorphine and I'm in naloxone, and then he transports them to an ED that has no idea what that is, that's a problem. So just like if you identified someone with an ST elevation MI and brought them to a hospital without a cath lab, that's a problem. We came up with this idea of a receiving center where you've got an emergency department that is expecting these folks to come in from EMS and is able to provide higher levels of care, adding on hepatitis C screening and substance use navigation and allied bridge clinics and that kind of model, almost like a trauma care model, but for opioid use disorder.
It just makes so much sense.
Right?
It seems like, there could be like some social science research too, kind of
Right.
going at how, because I always kind of see EMS as sort of being a traumatized group of providers a lot of the times, like they see the worst of people as well. And kind of having something that can so profoundly have like a really quick positive change can help, I think, change their attitudes too. So trying to like measure more of that would be,
Right.
I think, really meaningful and help us. But thank you so much. Wow. So impressed.
Well, we'll see. Just getting started there. The other piece with EMS is that, they're cross entity. So if you can recruit them as advocates, they're a great way. They're a great way to grow the model. So if they have a great experience, they might go to another county or another hospital, and they become the emissaries or the advocates, so to speak, of this new culture, which is another reason to invest in paramedics.
Thank you. So there are a couple more that have come in. Can you speak to any screening your department uses by nurses or providers in triage for every patient to help identify those who might benefit from buprenorphine but have presented for an unrelated complaint? I think some of your signage in the registration and
it's a complicated thing that I feel like I don't make sense sometimes when I talk about this. But it's the basic principle is that, if you screen, but people don't see that there's a benefit to disclosing their disorder, it doesn't matter, right? Because they're just going to say no. So I've seen some people put in universal screening, but it's kind of a check the box thing where it's not done, where there's no expression that this is a good idea to reveal this. So the results are terrible, but they can kind of pat themselves in the back. They're like, oh, I do universal screening and there's no one who needs help. I mean, I've literally seen that. So I really like people leading with, if like, let's say, you walked into a Subway shop or a McDonald's, they don't screen you for hunger, right? They offer you a really juicy hamburger, that you can self-identify that, yes, I want that thing. And as physicians, we've been kind of squeamish about like just offering buprenorphine on their terms. It feels almost inappropriate, like, oh, it's supposed to be part of this organized treatment agreement, blah, blah, blah. But just kind of offering it, I think, is the single most successful thing. That being said, I think, the overdose, there is a role for screening, because some people will also be benefit from that specific question. So right now we have kind of this thing where we do universal screening at discharge. So the initial offer is the signage, but then before you go, the nurse is this a drug related visit? Was there any overdose there? And it's kind of linked to a suicide screening. So that's something that we're just starting now. That then that's got to go somewhere. Who's going to follow up on that screening? So that's where your substance use navigation, some kind of registry way to focus and measure interventions on high-risk people like post-overdose or co-occurring suicidality and use disorders, these things. So it's a mixed message of lead with culture, but follow behind with structure and screening.
Yeah, I agree. I hadn't really thought about it that way when you talked about this kind of unintended consequence of screening. And I think it's really a subtle and important thing to be thoughtful about as we move forward. I don't want to suggest that we stop screening, but I think you're absolutely right that we set people up to say no and sometimes be on the defensive, and we end up having to undo some of that. And there's a long history of kind of that tension in medicine and substance use disorder interactions. So thank you for bringing that up. There's been a question about when how or when do you use kind of the larger dose rapid induction strategies, kind of 16 to 24 milligrams of buprenorphine, what patient subtypes, and then how long do you watch people, sort of as we can give you this dose of medication and then hopefully you can follow up in a clinic for continued medication in the next couple of days. It gives people a little bit of a longer window, right?
Yep. Yeah, that's the idea. So we're really pretty comfortable with the higher dose. So it's probably what happens most often. The way it really works is you meet the patient, and then you get a history of, are they a light, medium, or heavy user? And it seems kind of silly, but people really put themselves into buckets. So so you've got a person who's taking 3 Norco 10s a day. That person should not get 32 milligrams of buprenorphine. That's just ridiculous. So they're going to do great with 4 or 8, and they're really able to self-identify. But if someone is using 3 grams of fentanyl a day, or injecting heroin, 4 milligrams of buprenorphine there's just no way it's going to hold them. So there is that, in pain medicine, it's all about, matching, MME's intolerance to dose. In buprenorphine induction protocols, that got a little bit lost, but it's real, that some people need more than others. So generally, the people who are going to get the higher dose are people who have heavy habits, and have some barrier or limitation, or challenges success of initiating or continuing their prescription after discharge. Right. If they've got a bottle of buprenorphine in their hand, there's no reason to hold them in the ER to give them 32. But if they're going to have to go and deal with some logistic reality, then the more that you can get in that patient, the better. The exclusion is going to be people who are very old, people who have coexisting disorders. Just because you have a diagnosis of COPD, that's not an exclusion. But if you have an active COPD exacerbation, if you're sick, then we do not do rapid high dose inductions in those people. Does that paint a picture at all?
Yes, absolutely. I'm trying to see if there are other things that I've missed in the chat.
We haven't talked about precipitated withdrawal.
Yes. So buprenorphine precipitated withdrawal.
What do you do?
Yeah, that would be a great topic to touch on.
Yeah, we don't know. So, but the things that I think it's pointing towards are, one is that if you've got mild withdrawal, like real mild, the clonidine and that kind of stuff can be comforting. But once you have true bona fide precipitated withdrawal, I would just not do the adjuvants. It's just going to what I find is something like clonidine. All it does is confounds your exam. So it changes their pupils, but they don't feel any different. And so you don't really know where you are. But if, so our current approach is if you have, severe, like real precipitated withdrawal, you feel awful, not just a little worsening withdrawal or untreated withdrawal, but you feel awful, is to start with at least 8, if not 16 milligrams of buprenorphine. So, and what that is that once you've crossed over, there's no point in kind of going slow. Like if you've already precipitated withdrawal, you're not going to make it worse by more buprenorphine. You can only really make it better. So give a nice healthy dose of buprenorphine, 8 or 16 milligrams, and consider just combining that with a little benzodiazepine. And it not like a 2 milligrams PO lorazepam or equivalent. And just do that as quickly as possible. What I find is sometimes when the precipitated withdrawal event comes on, people aren't used to it and they're a little bit skittish. And so everyone scatters and it just gets, the patient feels the stress. There's a delay. Just jump on it. Just give them 2 milligrams of lorazepam plus buprenorphine and see how they do. If they don't calm, they're either going to get better in that the sort of escalation will stop, but they still might not feel that great. They're just like, I feel, yeah, okay, I'm better, but I still feel crummy. Then you can give them more buprenorphine, another 8, another 16, depending on your comfort level. The thing that can go wrong is delirium. So that's really what drives the M&M sort of bad cases, are that someone they get crazy. I've never seen it, but I've heard about it happening, and I think it has to do with early management. So if you've got someone who's, their pupils have closed down, they're no longer drenched in sweat, but they're still delirious. One, make sure they're not withdrawing from benzos or alcohol. It's just really common hidden there. And if you have any suspicion, treat it. So with your benzodiazepine. And if that's not it, if there's an agitation piece, treat it. You're an ER doc. Treat it like agitated delirium coming in for any other reason, someone on stimulants or whatever, and give them a healthy dose of an antipsychotic. And that simple protocol is going to mean that you won't ever admit or intubate anyone ever for precipitated withdrawal.
So we have a couple of folks on listening that are really interested in kind of data and active surveillance of opioid use disorder and treatment. And so they're curious about just kind of your opinion about how to distinguish those in kind of big data sets of surveillance who are new to buprenorphine treatment versus those who are continuing. So I guess the root of it is we see, you showed us those trajectories, which I think we see in clinical practice, and it's helpful to visualize it that way. But in the pattern that's people enter treatment and then leave treatment and then enter treatment, how is there a time point or a duration of time that you feel like would mean that someone's re-entering treatment it would be a new initiation as opposed to a stutter? And it may be an impossible question. I don't know the answer, but
yeah, I can just sort of empathize with that person, is that we struggle with the same thing. I feel like a lot of policymakers and, there's this idea of this linear, you find someone in the wilderness, you pull them out of the wilderness, you start them on buprenorphine and off they go. But the reality is so much more complicated. And so when you're trying to report out numbers, is this an initiation? Even this new billing code, MAT initiation, when is this a rescue, for someone who got started and they ran out and they're about to go in withdrawal and you give them buprenorphine? What is that? If they return to use for a week, I don't have any good answer to really defining that. It's all driven by research and reporting, in the sense of like, we'll define it basically on the lunar cycle, like 30 days. It just doesn't make any sense, but it's what we do. So if you're starting buprenorphine this month, and you haven't had buprenorphine the last month, you're a new start. I think that the sort of cascade of care idea, the, identification, exposure to treatment, retention, that's the larger paradigm. So being exposed clearly means something, whether or not that was continued today or in 2 weeks, because you'll see with those trajectories that when you do your follow-ups, there are people who didn't follow up at 7 days, but then do follow up at 28. So I feel like I was not very helpful there.
So are there any, I don't see anything else in the chat right now. Anyone is welcome to speak up. Otherwise, I can always ask more questions.
It would be great to hear from the audience. When we did the polling questions, a lot of people reported that they had protocols in place. So it would be really interesting to see what the barriers they're experienced to expanding care, or whether or not they're within, an ED setting, or if the problem is around linkage. So there's a question from Shannon Lawrence. Shannon, do you want to speak up, or would you rather us read it?
No, I'm here. I work for an inpatient treatment facility, and I've worked in the substance use field for over 20 years, and
Wow.
I have issues. I have issues with staff, and there's medical staff, inpatient coming in, they're going through withdrawal. We can get them on MOUDs.
Yeah.
The sad thing is they'll come in and the client has high hopes. They want to taper. They have high hopes thinking this is not, I don't want to do this forever. But when it gets time to do that taper, their anxiety raises, they're scared to death, they're feeling the withdrawal. You can literally see them start to decline. You really can. Mentally, you can really see them start to decline. So there's issues that I have with staff that were like, oh, they said they're going to taper. So they are already set dead in that. And I'm advocating going on saying, look, you know what? They're not ready. This is, what I'm saying? This is harm reduction. We've got to keep them in this safe place. If we do not, what's going to happen if they get up and walk out of that program is there going to be a needle stuck in their arm and they're going to die. And it's an ongoing fight that happens. And no, I'm not medical. Yes, I get that. But it's about what can happen to start getting medical. One of the sad things is you have a lot of people in the program that are in recovery, working in recovery, that already have biases and stigma about using MOUD in the begin with.
Yep.
That's that's part of the issue.
Yeah. I mean, I think that the stigma around MOUD and the stigma around drug use are really intimately associated. It's really hard.
Absolutely.
Right? Because at some level, if you're really judgmental and take a moral view of using heroin, it's really inconsistent, honestly, to then not be somewhat judgmental of using a substitution for heroin, because they are fundamentally mu opioid agonists. There's a mystique around buprenorphine that that I use and employ, but it's an agonist, it's an opioid. And people internalize that. So it's this funny thing of just sort of allowing people the space to maybe give up some of the self-judgment about their previous use, that using heroin is not the worst thing in the world you can do. The repercussions of it can be very real and very awful and and very impactful, but it in itself is a fairly natural human instinct to seek intoxication and pleasure and reward. This is what all of us experience this. And so getting at that so that they can see that this is, it is a substitution, but it's something that works really well, so that they can undergo that complex and, just real neuromodulation that has to occur when you abstain, when you withdraw from an opioid, when you're tolerant. whether you're, a 5-star general that has a knee replacement, or someone who's using street opioids, you've got a mountain to climb, and it's gonna have stress, anxiety, physical discomfort associated with it. There's no way around it.
Absolutely, absolutely. And I agree with you on that. But it's when the participant does not feel like they are ready. And if they are not ready and not being able to put in other skills, and then they take them completely off, there's that harm on them up and leaving a treatment facility.
Oh, yeah.
Harming themselves. And I think that's one of my biggest issues on fighting with others on, look, they're not ready at this point in time. Where is it where we meet them where they're at? And I don't feel like anybody's hearing me in that aspect.
Oh, I'm sorry, Shannon. That's tough, and it's just wrong, right? It's just a reality that when to coerce
and that's where
someone,
your biases, that's where all that comes into play. That's when that discrimination, those biases, and they all come into play. And the sad thing is, a lot of the ones that are in recovery, working in recovery, they came from there, but thinking because their road of recovery worked for them, they're thinking that should put into play for others in recovery. And that's where an issue lies as well.
Yep. Yeah, this is the sort of $1 trillion question, right? All your experience multiplied across 50 states and how many thousands of counties. Like it's a lot of people are in this situation that you're talking about, and it's one of the biggest challenges ahead we have in the country.
Yes,
is
absolutely.
to overcome that. Yeah,
absolutely. I did want to say, Dr. Finucci, I did want to tell you that previous workplace, I know that you treated several of the patients that I had, and I just want to tell you how grateful and thankful I am for you, because you saved their lives.
Oh, there you go.
You really did. And I know this, and they spoke highly of you, and literally you saved their lives. And just to say that they are still, this is several years later, they are still doing phenomenal and living very great productive lives because of you.
Wow.
That's here. I'm glad people are doing well. That's why we're all here having this conversation. I think those of us that work in this space see that people really do get better. And it's like Dr. Herring said, if they're not alive, they don't get the chance to get better ever. And so
thank you. Absolutely. I agree. But literally when I heard your name, I'm like, oh my God. It's like, yeah, because I've heard your name several times in several of my patients, and literally it's just, I'm honestly, no kidding, so grateful, because I know they have families, they're working jobs, they are just, it's remarkable. It's honestly, I guess that it's one of the things why I keep going, because I know that you can recover. Whether some of them are still on medication, but you know what? They're alive.
That's great. That's really great. Bravo.
Well, we're approaching kind of the end of our session. And I don't know, Sharon, do you have...
Well, there was another question in the chat from Jeff McGowan. I don't know if Jeff wants to ask the question.
Hi there, can you hear me?
Yes.
Okay, I was just wondering, is there an optimal time frame for recommended follow-up after successful MAT initiation from the ED?
Sure. I mean, as soon as possible. And with telehealth, again, this doesn't need to be complicated. You to continue MAT or MOUD or buprenorphine initiated in the emergency department, people should not need to have to do complex behavioral intakes to treatment. That can happen later. So ideally, everyone leaves with a number that they can call, and that someone they can talk to the next day. That would be my recommendation, because it's doable. You know, it's just not something that many clinics have focused on. And there can often be misaligned incentives around, you know, intakes and defining populations and stuff, but pushing people just to have a drop-in clinic that's available, you know, most days of the week, like that's the system that's going to work. What you'll see is that if you set up a really successful ED program initially, depending on what the access is in your community, you'll see increases in visits. So you'll see more people coming in, either people that would have been there and would have been there anyways and now identify as OUD, or, you know, they bring in their cousin and their friends and the word gets out. And so the visits go up. Then if a bridge clinic matures and really is able to, you know, a bona fide bridge clinic that paid low threshold, easy access, then you'll see that the repeat ED visits really go down and people will preferentially go to that clinic instead of the ER. But it takes an evolution. It takes time to get there.
I see actually that Jeremy Carpenter has his hand raised. Did you want to ask a question, Jeremy?
Yeah, I just had a quick question on just the data you're tracking. Do you have any data points you can point to on conversion from your program to treatment? And is that the conversion rates, are they more successful when those bridge scripts are smaller, larger?
Right. Yeah, this is really interesting. We're, you know, looking at this now, but COVID, right? So COVID, we went from, you know, 3, 4, 6, 7 day prescriptions to a month, right? Because it was just basically like, you show them the ED, we don't know what's going on, we don't know where you're going to go, you need to be safe, so here's a month-long prescription. And this happened all over. So there's this overnight change from this rather parsimonious, like, I'll just give you a little bit here, and then you're going to have to connect that to another doctor to extend it, to like, you know, here you go, a month. So we don't really know the answer. My sense is that, you know, that just everything just sort of boils down to access, resources, tools, flexibility. So there's just only upside to using longer prescriptions. So, and that from a patient standpoint, so if they've got a longer prescription and something unexpected happens, you know, people are so mobile, you know, their mom in 2 states away gets sick and they have to go take care of them, or they've got more buprenorphine, they're less likely to drop out of care. The logistics come in is that if you're using long scripts from the ER, one, your pharmacy, right, literally might run out of buprenorphine if you got multiple people filling month-longs. And it just becomes a problem if you're losing month-long prescriptions routinely, which in that, it just is a little awkward. You're like, well, you've lost your like 3rd month-long prescription of buprenorphine, you know, in the last week. That's going to be hard to sustain. So there's some middle ground where emergency physicians should feel absolutely empowered to do long prescriptions from the get-go, a month long, absolutely. But they also should have the discretion of like, okay, it sounds like we got a reasonable follow-up for you in the next couple of days. I'm going to give you some wiggle room. I'm going to give you 14 days, you know, as a maybe a middle ground, or in some circumstances to keep it tight. It's just I think it's a clinical decision there.
Thank you. I think now I really don't see any more questions. Sharon,
Scraping the bottom of the Haagen-Dazs here.
The question as you're walking out the door, right? So any
I love it.
hand on the door questions are just fine. We welcome hand on the door questions.
Well, this is Sharon. I don't have a question, but I do have a comment because of the conversation that took place between Shannon and Andrew. And the way that it ended was, it's okay if people are still alive and they're still on their medicine. And it just struck me like, what condition would we ever think that we needed to say something like that about? How many people are alive because they are on medicine, right?
Yeah,
I mean,
Right.
that is so crazy. I mean, that just to me epitomizes the amount of stigma and ignorance. And I'm not saying that about this group. You're all here, you know, because you've got a vested interest in this. But in the healing community study, we often say that in addition to the enormous amount of work that we're doing in the communities, that one of our main jobs is to change hearts and minds,
Right.
and change the conversation. And I just was so struck by that kind of final pearl that conversation ended on. You know, would we ever say that about any, like, oh, it's okay that grandma's still alive, you know, even if she still has to take her heart medicine or whatever,
Right.
right? I mean, this is, so I just think that we need to really be thoughtful about always trying our best to convey the fact that this is efficacious treatment. It's actually the treatment that we have the greatest evidence for, that is life-saving, right? I mean,
Right.
talk therapy is one thing, does no evidence that it saves lives. And so if what we're trying to do is keep people alive so that they can do all the other things that, Andrew, you said you're not promising, like, we're not talking about your full recovery here tonight in the emergency department, but eventually that's the goal. That's what we want, people to have meaning restored to their lives, and to restore all their relationships. That is, you know, that is what this medication can do. And I think that that's the way that we need to frame it for people.
Yeah. I mean, I'm interested to see what you think. I mean, I think there's this cognitive dissonance between criminalization of use,
Right.
and it's hard to, like, in one half of your brain consider someone a criminal for their behavior, and then the other half of your brain destigmatize and consider it like diabetes, you know, because you can't be arrested for eating your Captain Crunch. So
Right.
that's why I feel like, as awkward as it can be, physicians need to enter that discussion.
Well, and I think that you started out too with first do no harm.
Right.
And if you know that withholding effective treatments causes harm, then you're not actually abiding by that oath.
Right.
And
right.
so I don't think any physician, you know, is intending to do harm, but they are doing harm.
Yeah.
Because of this. And so I think that changing that dialogue around that also is really important.
That's right. Yeah, that's right.
And I don't want to criminalize Captain Crunch.
Right. Guilty. So it's going to be exciting, a couple decades here. I think with policy, culture, treatment, where we are today versus where we're going to be in 10 years, I think it's going to be different.
Yeah. I mean, we've seen a lot of change over the last few years. We've seen a lot of change in policy. The pandemic had a silver lining of changing some regulations that were in place for the last 50 years that were pretty draconian.
Right.
So we've done this big natural experiment with telehealth. People actually still make it to their appointments. Some make it to their appointments better because now they don't have a transportation issue.
Right.
I think that we're going to continue to see advances, both scientific and policy advances, but it's the people that are here that are going to make that difference. I mean, we are the voices for the people that don't necessarily have a voice.
Yeah.
And doing, a lot of the innovative work like you're leading is really helping, and it's, somewhat contagious. And we want it to infect all of Kentucky. That's what we really want.
That's great. I love it. I love it. And then, and I'm just one tiny piece. There's a lot of amazing people at the California Bridge, other physicians, nurses, PAs, pharmacists. So, please, I'm just a tiny little perspective of a really big project, a lot of wonderful people that would be very invested in also helping.
Sure. All right, Laura, do you have any closing comments that you want to make as moderator?
No, I don't think so. Other than just I'm thrilled to be able to have this conversation with everyone, and I really hope that we're able to continue to move this forward in our state. I think the work done in California is really a wonderful model, The other thing I would share with providers is it's really fun and rewarding to do this work. People really get better, and I understand in the ER it's sometimes hard to not have the follow-up and see only people kind of at their worst moment. But I think as Shannon mentioned, down the road, people do get better. And it's really kind of it's a rewarding space in medicine to work.
Thank you, Laura. And April, I think that you have a couple of announcements.
Yeah, I just wanted to thank Andrew and also thank everyone for coming. And this is our first of many learning collaboratives. So if you have suggestions for us on topics or speakers or anything of that nature, please do write us or put it in the chat. You can private chat me if you'd like. And then we do have a feedback form that will be coming to your inbox soon. And I believe, yes, they've put it in the chat. So if you want to go ahead and click that and fill out the quick feedback form, we would appreciate your suggestions for how we can keep improving. So with that, I'll turn it back to you, Sharon.
Yeah, thank you, April. I just want to thank everybody that participated today on a Monday from 5 to 7. I'm very grateful to you for taking the time out of your day to do this. It really shows how important it is to each and every one of you. I hope that it can make a difference. The Healing Community Study is here to help facilitate change in the communities. We've got a lot of work that's underway in our Wave 1 communities. If you're unfamiliar with what we're doing, we're always happy to share that with you. We have a lot of technical assistance available to help physicians and other providers to improve practices. We're working with a number of our hospitals to try to get this type of initiative that Andrew talked about today underway in our communities. We're pouring naloxone into our communities. If you work for an agency in one of the Wave 1 counties that doesn't have it yet, you just need to reach out to us. And then, of course, I really just want to thank Andrew for agreeing to come and talk about his important work. I know it takes a team. It's not just you, and you have to be surrounded by great people to make this kind of change. But you have really awesome experience, and you are willing to take risks, and you are also willing to take those ideas and put them into good science so that we can get evidence around what really is effective. And so I'm very, very grateful to have you here today. And I just want to thank you on behalf of all of us.
Great. It was just a total pleasure. And, you know, I am truly obsessed with ED buprenorphine. So all the ER physicians out there, so the complex cases that you couldn't make up, that, you know, I'm happy to share my contact information. I love hearing about when things, you know, this is how we learn. So the more I learn about cases that didn't go well, honestly, the better I get at these. So that's an open door.
Thank you. Thank you so much. And thank you, everybody. And I hope that you have a great evening.
All right.
Take care. Thanks again, Andrew.
Bye, everybody.
Bye.
Bye.